Hey everyone, this is Soph, and you're listening to the Beyond Pain and Fatigue podcast, where together we'll explore the complexity of chronic pain, fatigue, and invisible illnesses. Hi everyone, and welcome back to Beyond Pain and Fatigue. My name's Sophie Shepherd, and today I am very excited to be joined by Anne Wilson, CEO of Emerge Australia, the leading patient organisation for people living with ME/CFS in Australia. Anne has spent her career leading and transforming organisations across the health, education, and not-for-profit sectors, with a strong focus on advocacy, education, research, and service development. An award-winning CEO and graduate of Stanford University's non-profit leadership program, she brings extensive experience in driving systems-level change and improving outcomes for people living with complex and under-recognised conditions. Anne is actively involved in health advocacy both in Australia and internationally. Beyond her work at Emerge Australia, she also currently serves as a director of the Australian Patients Advocacy Association, is a member of the NDIA Neurodegenerative and Palliative Care Advisory Group, and is director and secretary-treasurer of the International Kidney Cancer Coalition. With a deep commitment to amplifying patient voices and to social justice, Anne has been a passionate advocate for increasing awareness, research investment, and better support for Australians living with ME/CFS. I'm so delighted to have her join us today. Thank you so much for joining us, Anne.
That's a pleasure. Thanks so much for having me.
I'm so excited. I feel like there's so many questions I want to ask you, and I'm conscious we've only got you for a limited amount of time. But I think it would be really exciting and helpful for people who are potentially maybe not as familiar with Emerge Australia and the work that you do. Would you mind giving us a bit of an overview as to what Emerge does and maybe the role it plays for people who are living with ME in Australia?
Yeah, sure. Well, Emerge Australia's been around for a while, about 30 years actually. And particularly in the last 5 or 6 years, we've really ramped up our work across, as you said, education, advocacy, research, and support. And we are the leading patient organisation in Australia for people with ME/CFS. And our work really spans across clinical education because that's what patients tell us is the biggest issue. Where do I find a doctor that knows anything about ME/CFS? So that is one of our major pillars of the work that we do. We also, of course, advocate for health policy change and inclusion in health policy, not only from a service delivery perspective, but in collecting data about ME/CFS, which I can talk a little bit more about later on, is going to happen for the first time this year through the Australian Institute of Health and Welfare. We also run a biobank. So biomedical research is an area that we're heavily involved in. I've got 2 scientists working on our tiny, tiny team, and we have a biobank. We collect bloods from people with ME/CFS, long COVID, and healthy controls. And we also run a patient registry. So we've currently got over 2,500 people on our registry, and we've got 25 research projects around Australia that are utilising our data and our bloods for their research work. So research is a really important part of our work, and we do that research in conjunction with La Trobe University in Melbourne. Then finally, the major part of our work as far as reaching out to patients is concerned and supporting them is our patient health services, and they span both information services and direct service delivery to patients through our telehealth service. So that service supports people not just with ME/CFS. We support people with a range of overlapping conditions. So it's ME/CFS, it's long COVID, it's other energy limiting conditions, it's post-infection fatigue syndromes, and also, mitochondrial disease, connective tissue disorders, fibromyalgia. So we do that not just through telehealth, but through our learning management system that we've developed online so that people can actually go online and do some self-paced learning and educate themselves at their own pace about things such as post-exertional malaise, pacing, what to do in specific circumstances, as well as obviously eligibility for things like the National Disability Insurance Scheme, and disability support services. So that's all comprehensively available on our website, and that is managed by our patient support
It's
team.
fantastic work that you're doing. And I know as someone with ME myself, but also as someone who clinically supports a lot of patients living with ME, but also long COVID and a lot of these overlapping conditions that you're speaking about, Emerge has been a really fantastic resource for me to be able to sort of direct people to. So I can only imagine the volume of work that has gone into setting that up. But it's so impressive and such important work that you're doing from the perspective of being representative of patient experience, particularly. I think that really offers quite a unique perspective that sometimes I think we maybe don't hear as much about. I guess from the research, but also from the stories you hear from patients, like what do we know about the experiences of people who are living with ME, CFS? How does it affect them? And I guess what do we see in terms of how it impacts their life?
There's one really quick answer to that, and that is that patients tell us that having ME, and that's particularly at the severe and very severe stage, is like a living death. That's what patients tell us. It's like a living death. They're alive, but it's like they're dead. They can't function. They can't do anything for themselves. Those at the very severe end of the spectrum are often hospitalized. They often have got feeding tubes, or are home and are bedbound and therefore can't get out. They crash whenever they do the slightest bit of, exertion, and, they've lost their lives. And I mean, for someone who doesn't have ME/CFS, and I don't, just the thought that, you go to bed at night, you're exhausted, and you wake up in the morning and you're even more exhausted than when you went last night because something in your body's battery is faulty and it's not recharging overnight. And it won't recharge until such time as it's plugged in, and it's plugged in for a long time, and then slowly but slowly you reach charge. And that's why we adopted the battery as our logo a couple of years ago, because it's not necessarily easy for people to understand what ME/CFS is and how it affects people. So that battery analogy is a really quick and effective way of letting people know, well, if your battery's not faulty and it is recharging, well, then you're one of the lucky ones. But if you're not recharging and you don't have the energy to do what most people would regard as, the slightest things, getting up in the morning, having a shower. For some people with ME/CFS, getting up in the morning and trying to have a shower will crash them for the next 3 weeks. And then they won't be able to have a shower and they won't be able to get out of bed for a long period of time. Now, that is really hard for people who don't have ME/CFS to actually comprehend how it happens. So imagine the challenges that someone with ME/CFS has when they're trying to explain how they're feeling to their GP, let alone their families, um, and let alone trying to relate to a peer group, whether it's, young people, your own friends. What ME/CFS does to people is it isolates them. It isolates them from the external environment that all of us take for granted. And therefore, the world of someone with ME/CFS becomes unbelievably insular and small. And it just is like your life is taken away from you, but you're still alive.
Absolutely. It's such a difficult thing, I think, if you have not necessarily lived it yourself to actually understand that feeling and that people's bodies don't respond in the same ways. And certainly that's something I've heard from several of my patients who I've worked with who have been on the more severe end of the spectrum in terms of symptom burden. And I think, as you mentioned, just the impact of that on then actually seeking care and having people not only understand symptoms, but also just the burden of accessing healthcare, I think is a huge thing as well. Because, from some of the patients I've worked with, even when it comes to our sessions, which are, I've done over telehealth, we've had to have very often very micro appointments where we're limiting direct contact to sort of 5 minutes or less, if that. They're accessing that from bed, and then maybe I'm working more directly with one of their family members or a carer who can kind of help support them, because just the burden of actually sitting in an appointment and the cognitive load involved in that can be enough to trigger symptoms. There's a real sort of cost benefit there, and it makes it really difficult. Something you touched on there, I think, is, in the communication of symptoms, there is this sense, and certainly my experience has been that often because there is sort of this poor understanding, that it can actually lead to sort of quite, sometimes quite negative experiences within the healthcare system. I wonder if you'd be happy to share a bit more about that and some of the things that you've seen and heard from people about their experiences accessing healthcare.
Accessing healthcare is a big deal for people with ME/CFS because, for example, currently the regulations around being able to access telehealth in Australia hinge upon someone seeing their GP face-to-face once a year. Well, for those people who are very severe, that's not possible. So what you find is that these people who are very, very, very sick will tell you, well, I haven't seen a doctor for 3 years, because in order to access a telehealth consult, they have to have seen a doctor. And if they can't see a doctor, then they don't access clinical services. And we've been advocating for changes to that rule for a long time. We haven't succeeded yet, but we will ultimately succeed. But it's a huge challenge. So that's a systemic challenge that impacts the ability of those that are really severe to be able to just go and see a doctor. I think the greatest challenge that faces patients when we're talking about, being seen by a doctor, let alone being heard, is medical gaslighting. Several years ago, we ran one of our first parliamentary friends groups in Australian Parliament House, and one of our members of our Medical and Scientific Advisory Committee, Dr. Mark Donohoe, actually stood up and said in quite a large forum of people, medical gaslighting by GPs has to stop. That was an absolute admission of the fact that we have clinicians out there who just don't believe their patients. They gaslight them. They'll say that, all their test results are normal, therefore you just need to take it easy, and you know what? You're probably just deconditioned, so why don't you do some graded exercise therapy? And to help you, maybe go and have some counselling, because, this might also be psychosomatic.
Absolutely. And I think that model of assuming that symptoms are the result of deconditioning and often linked to that fear avoidance as well. I've seen had patients where it's been assumed that, oh, well, you're fearful of symptoms, and so you're avoiding activity, and that's making you more deconditioned. So if we just fix the way that you're thinking about things and we get you moving more, then that will solve all your problems. And I've certainly see that playing out in my experiences as well. It's so difficult. And I think, there's potentially so many contributing factors to that. I guess I'm interested from your perspective, do you feel that that's predominantly just a lack of awareness and training, or are there potentially other factors sort of layered into it that lead to these sort of experiences?
I do definitely think, and we know, that doctors who are out there right now, most of them have not been trained to be able to diagnose, manage and treat ME/CFS effectively. We know that, which is why a major focus of our work, which I might add is completely unfunded, is on clinical education. It's really, really important. But the thing I think that frustrates me more than anything else is that it has been proven, and evidence is absolutely conclusive, that ME/CFS is actually a medical condition. It's as a result of what's going wrong mechanically in your body's battery, whether it's your mitochondria that are not functioning properly because the effectiveness of the mitochondria is critical, or whether it's your cytokine inflammatory response that becomes overactive after you've had an onslaught, whether that's an infection like COVID, or whether it's the flu, or whether it's for some other reason that then your system doesn't actually turn off and it just keeps going. Long after the infection is gone, your system has been damaged in some way. And the fact that there is, in many quarters of the medical profession, a total disregard for what is clinically happening in a person's body when they've got ME/CFS. It's like a stubbornness that is there in some clinicians. And I guess I'm talking largely in the GP world, because that's the first port of call that a patient goes to. I'll go to see my GP. Now, I can tell you that Emerge Australia does a lot of GP education. And we do that largely through conferences that educate GPs. So we will either have a speaker, one of our clinicians, who will speak to either 1,000 or 2,000 or 250, depending on which conference we go to, and they will do targeted clinical education on ME/CFS and long COVID. Of course, COVID has helped the sector immeasurably because of long COVID and the fact that the evidence now exists that people who have long COVID for at least 3 to 6 months actually have got ME/CFS. So that's taken 5 years to get to the point where we can say that evidence exists. But I can tell you that when I'm at these conferences and I see doctors come to our booth, so we have a doctor speaking, but then we have a doctor come to our booth, I'm mortified at what some of the doctors who come to the booth say. We have GPs who'll say to me, "Oh, I don't want to know about that because the patients just make it all up." I had someone say that to me this last weekend, and I just shook my head. Then we have other people who say to us, "Look, I don't want to see these patients. I don't want to see these patients. They take too long and I can't do anything for them. So better they don't come to me." You know, I've got lots of anecdotes of what doctors have told me. Now, it's really important that for anybody listening to this podcast, understand I am not having a go at GPs or the medical profession, but there needs to be a recognition that the majority of clinicians out there who don't work in the ME/CFS space really don't believe that there's anything that can be done, and they actually out of sight, out of mind for those patients because they don't know what to do. There is another systemic issue that says that MBS reimbursement for clinicians needs to recognise the longer consults, and in fact that has now happened on 2 occasions where government has made changes, but further changes still need to be made because these patients, in the words of our former medical director, Dr. Richard Schloeffel, they take time, not because the patient's talking all the time, but because the clinician needs to listen to what the patient is saying. They need to build that relationship to help them better understand exactly what's going on, and then to look at, what a differential diagnosis might look like, eliminate all of the other things that it could be to get to the point where you're saying, well, I do think that it is ME/CFS and this is what we have to look at therefore. But, So many
Mm.
of the doctors that we speak to in conferences will tell us, I just don't want to see these patients.
It's so challenging, isn't it? And I mean, in a way, I can understand to an extent that whenever we're working with any complex condition or illness, I can understand sort of the gut reaction of, oh, I feel uncomfortable and uncertain, and this is something that I'd sort of rather avoid, because it's nice when we have the straightforward, linear, easy stuff coming through. There's something nice and easy about that, we can move through our day. But I think the inherent uncertainty and complexity of how a lot of patients present with ME can be quite challenging. And I think I can understand to that end where maybe some of that sentiment is coming from, but I also really don't think it's an excuse for continuing to, ignore and not take steps to sort of help prepare ourselves better. I think the response shouldn't be, well, how do I avoid these patients? It should be, how can I upskill myself to, be a better place to support them? And it's such a tricky thing.
We understand this is a really difficult diagnosis to make, and it's one that takes time. And really, only those doctors who are dedicated to that field are the best to, from a patient's perspective. But of course, they're few and far between, and they're spread all over Australia. So, we need to understand that, and this is something that we talk to government about all the time, that investing in clinical education for this cohort of patients, of which 75% are women. That's the other very, very important thing. And often what happens when I speak at something and I say 75% are women, that often some of the men in the audience will say, but what about me? And of course, that's not in any way to discount the impact on both males and females. But it is true that 75% are women. And it's also true that in this age where our government is allocating millions, hundreds of millions of dollars to women's health, that the women with ME/CFS also suffer from all the other conditions that are currently being funded in women's health. So, but somehow women with ME/CFS, oh, well, they don't really matter. Well, we won't really talk about them, okay? So, and I think it works out if you work on the figure of 250,000 people in Australia, mostly undiagnosed with ME/CFS, it's about 167,000 women that we're talking about, So, it's a major issue and it's challenging. It's important that organisations like Emerge Australia really understand what's going on from a systems perspective and try to work hand in glove with the colleges, with the patients and the clinicians. And one of the things that has happened in the last 12 months, which we're delighted about, is that the Deputy Chair of Emerge Australia's Medical and Scientific Advisory Board, Associate Professor Bernard Shue, is the inaugural chair of the Energy Limiting and Post-Infection Disease Special Interest Group of the RACGP. Now, it may not sound like a lot to a lot of people, but this is like a vehicle that I'm sure will deliver better outcomes in terms of raising the level of knowledge and understanding of GPs through the work of the RACGP. So, and I say that because we have to be respectful, not be critical. We can't just hit people over the head and say, you don't do anything, you're this, you're that. Doesn't work. We need to be respectful of the knowledge that our clinicians have got and understand and get behind the barriers that are preventing them from being able to deliver effective care to people with ME/CFS.
Absolutely. There's a few potential sort of directions I want to follow up on, and I think I'm going to go one way first because it kind of leads into some of this education and the need for getting better awareness out there, because I know very recently actually Emerge put out a joint communique that had some very big names on it, and I think was a really important thing. But I'd love to hear a little bit more from you, for anyone who's listening, to tell us a little bit more about that recent joint communique, and why it's sort of important in the context of this work you're talking about.
So just this last weekend, I was at a GP education conference called Health Ed, and I had our communique there, and I was giving it out to doctors. And the way I addressed that communique, because you know what it's like, people come up to you at booth and you say, this is who we are, this is what we do, blah, 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 and you give them, you know, some resources. So I said, this is the most important resource you need to have. I said, this has been written for you by clinicians to help you understand the difference between post-exertional malaise and fatigue. And I mean, that's where the rubber hits the road, because it's very difficult when you've got a clinical name of a condition called ME/CFS, or myalgic encephalomyelitis chronic fatigue syndrome. Everybody just deflects to the chronic fatigue syndrome, right? And they focus on fatigue. Well, fatigue is very different. You know, if I'm fatigued because I've had a really hectic day and there's been lots happening and I've been really working physically and mentally very hard, I'm fatigued at the end of the day. But as I said earlier, I'll go to bed and I will have a really good night's sleep, of refreshing sleep, and I'll wake up in the morning and I'll be fine. But if you go into a PEM crash because cognitively and physically you've overdone it, and I'll get back to the overdoing it in a minute, you will actually crash. And a PEM crash, I am told, means that you've actually got no energy whatsoever, but you just don't have it for overnight. You may have it for the next 2 weeks. And
Yep.
that's the message we need to get over to our clinicians. You need to think about whether this person has got post-exertional malaise, which is it's the key diagnostic feature of ME/CFS, or whether it is just fatigue. But you've got to diagnose that, you know? And so that communique actually has been one of the most popular. It's only a one-pager. And then on the back, we've got information about self-paced learning and our CPD, RACGP approved clinical education, which we do online. We run online as well. But that communique has been so well received, because the minute I say to the clinicians, this has been written for you, it's been written by clinicians, for clinicians, and you need to take this and have a good read and understand what we're talking about. And they all took them away and they said, oh, thank you for that. And we also then all gave them a symptom checklist that they could take to their surgeries and tick off the various symptoms. So that communique is proving to be very important, and we'll be doing more with that going forward.
Yeah, fantastic. And thinking about that, you know, that distinction between fatigue, which can come about from many different causes, not necessarily just ME/CFS, and like you said, PEM often being a much more severe exacerbation. I think often the thing that we hear and see clinically as well is that fatigue, like severe fatigue, is often part of PEM, but it's also only part of the symptoms. People often will have a lot of other symptoms at the same time, a lot of sort of immune type
Yeah.
symptoms and feeling of flu. So it's certainly, I agree, goes far beyond just, you know, fatigue, and differentiating the two is important. I guess when we think about the implications of that and why it's so important for clinicians to understand that, and I guess in terms of considering the potential sort of benefits or harms if we're not differentiating them, why is this so important for clinicians to understand?
Well, having them understand why they need to differentiate between fatigue that is caused by something else. And, you know, we need to be very mindful of the fact that, you know, people on chemotherapy have chemo fatigue. People with MS suffer from fatigue. There are a whole lot of conditions where people suffer from fatigue, but it is not the crashing exertional malaise that people with ME/CFS get. And I love the analogy of thinking about people who are pacing. As human beings, we are probably, a lot of us, and I'm one of them, quite impulsive. So if I get sick, and thankfully I don't get sick very often, but if I get sick, the minute I start feeling better, I go like a bull at a gate. Right, I'm feeling better. Right, I can do this, 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 and that. And invariably I'll go, oh, after a couple of days, why did I do that? Because I now feel sicker than I did when I started getting better. That happens all the time with people with ME/CFS. Imagine someone has been bedbound for 3 weeks after a crash, and now all of a sudden they feel better and they've got this whole list of things they want to, address. And they go, bang, I'm going to do this, 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 and this. And guess what? After 6 hours, they've crashed for another 3 weeks. Okay. Now, that doesn't happen to someone who's just got fatigue. And I'm not belittling fatigue. It's a major issue. But PEM is something different. And recognizing what leads to PEM, and also as the patient, I think patients have a responsibility here to say to themselves, okay, I need to do A, B, C, and D in 2 weeks' time. If I'm going to try to be able to do those things in 2 weeks' time, then for the lead up to those 2 weeks, I have to rest for, most of every day for about 6 hours, because that's what happens to the faulty battery. Another person will go to sleep, have a refreshing night's sleep. They'll wake up in the morning, they'll be fine. But people with ME/CFS don't have a refreshing night's sleep. So they need to plan ahead how many hours they have to rest, and it's called pacing, in order to get to that, whatever it is they have to do in 2 weeks' time, and have built up enough energy in those preceding days and weeks in order to have enough energy for that one day. And then they'll probably crash again. But it is about rigorously managing and monitoring your energy load, because you have a faulty battery. Your phone isn't recharging properly. So you've got to be very, very rigorous in how you monitor that. And another thing that is really important, because it cuts to the gaslighting and also how people with ME/CFS are perceived. One of the biggest challenges with ME/CFS is, apart from the fact that it's totally invisible, is that it's a fluctuating condition. So, if you've been very diligent in pacing yourself, and you have a couple of days where people see you and you've gone to the doctor, if you're one of the lucky ones, or you've gone out to pick your child up for school, or you've been able to attend a family wedding or a family function, people look at you and they go, oh, you're fine. Nothing wrong with you. It also becomes a huge barrier when you're trying to access NDIS, because fluctuating conditions that don't have a rigid diagnosis, get shoved out of the way, because, well, you came and you saw an assessor and you spoke to them about what your needs are, and they go, well, you don't have any needs, you're fine, you're talking fine. But the energy that it took that person to have that conversation, to get from point A to B, and to plea their case, and in the case of the NDIS, that's what it's been, and then go home and crash. The assessors don't see you going home and crashing. They see that you came and you were coherent. You were able to tell them about what the issues you've got and what your needs are. For them, they go, well, she's not in a wheelchair. It's invisible, isn't it? So these are the challenges, and I can only imagine, and yes, I've spoken to a number of patients, the continued slap in the face that people with ME/CFS get when they're constantly being presented with, well, you were okay yesterday, why aren't you okay today? Why are you bedbound today? But last week you came and saw me and you were fine. I mean, I just can't begin to understand, really, the level of frustration, anger, and just hopelessness that some patients feel.
And that would absolutely mirror some of the conversations that I've had with people. And I wish it were uncommon that I would hear stories like that and experiences like that. But unfortunately, very much not. And I know that from the conversations you're having through Emerge, that it would be not a surprise to you either that this is something that's happening, which is obviously heartbreaking to hear that this is such a widespread and common experience for people with ME. I think coming back to some of the content of the joint communiqué and the differentiation between PEM and fatigue and some of the importance of that, we've actually had previous episodes on this podcast where we've spoken about a lot of the issues around graded exercise therapy, for example, and how that is obviously no longer recommended as part of the NICE guidelines, for example, and that actively recommend against it. And largely that's because of these differences. When we're talking about general fatigue without PEM, then yes, graded exercise might actually be appropriate and suitable. But when we're talking about PEM, it really isn't. And because people, like you said, people aren't recharging their battery, they don't have that same response to activity and exercise, and their body can't adapt in the same way. Graded exercise therapy has actually been shown to be harmful. It's a very controversial area, as I'm sure you're aware. If anyone's interested in doing a bit more of a deep dive on that, please go back and listen to previous episodes because we have spoken about it a bit. But I think in the context of what you're talking about here, we've maybe sort of touched on some of the reasons, but when we think about those recommendations that have sort of since come out in recent years saying, look, we know there are these differences in how people respond to exercise when they have ME compared to other illnesses. We know there are these physiological differences. We know that there is evidence of patient harm with GET, and we now have guidelines that very clearly say do not do GET for ME. Why do you think that this focus or this tendency to default to GET has sort of persisted for so long in spite of all these things? Do you have any ideas around why that might be?
I think politically it's just been an entrenched position based on early studies like the PACE trial. And it's the brotherhood of clinicians that have banded together and said, this is what it's got to be. Now, in Australia, we've had, one particular clinician who has flown that flag that's been supported by the College of Physicians, that in my view has ultimately also been supported by prior, I really am very careful in what I'm saying here, prior chief medical officers. A bit of a brotherhood when you've got a prevailing ideology that you are committed to and all of your mates are supporting. It doesn't allow for other players to enter the field with new evidence. And I think that's what's been happening for a number of years. And in Australia, and Emerge Australia has been with the ME/CFS community fighting this battle for the last 5 years. And in March 2024, we won that battle with our current Health Minister, the Honourable Mark Butler, agreeing to fund new clinical guidelines for ME/CFS. And one of the major tenets of that process is to ensure that the new guidelines cause no harm. I mean, that's my understanding of what is being addressed. I don't know because I'm not part of the guideline development committee, but I do know that in the advocacy that Emerge Australia and I personally did to the minister, we had representation from several clinicians around Australia focusing on the evidence that graded exercise therapy causes harm. I say it's political because included in the rhetoric are colleges like the RACGP, who to this day refuse to change their handy guide and their recommendations on graded exercise therapy. It is like from a patient advocacy perspective, it just feels like a total vendetta it's not strong enough, but it feels like a clique. There's like a clique of doctors who refuse to accept the evidence around graded exercise therapy being harmful for people with ME/CFS, and they just point blank refuse to change their own handy guide, which recommends it. Yet they've got a clinical guideline process that we are hoping, fingers, toes, and everything crossed, will actually deliver what patients have known for the last 23 years, remembering that Australia's clinical guidelines are 23 years out of date, So it's not a simple issue of getting a group of doctors to say, look, we've got the evidence that graded exercise therapy causes harm to people with ME/CFS. If it were that simple, it would have already happened. And that leads me to absolutely believe that it is a very, very political hot potato. Can't say that I fully understand why they are the way they are, but we are bit by bit by bit trying to break that down. We can't go at it with a sledgehammer and say remove it. It doesn't work. It's being discredited bit by bit by bit. And look, there are clinicians in the field who work with people who don't suffer from PEM and don't have ME/CFS. They might be people who have got fatigue from medically medications, chemotherapy, immunocompromised people, etc., who suffer from fatigue, for whom a little bit of graded exercise is actually helpful, but it's not helpful for people with ME/CFS. That's not to say that someone with ME/CFS, let's say someone is bedbound. That's not to say that if you're bedbound, you can't maybe do some squish ball exercises with your hand for 30 seconds. Or you can't move your legs in a way that just helps with keeping some of your muscles working the way they need to. But that's not what graded exercise therapy really is all about.
Absolutely. And again, if anyone's interested in more of a deep dive around that, we have previously discussed graded exercise therapy and some of the differences and definitions and unpacking that. So there's if you're interested, go back and have a look at some of our recent episodes if you're interested in learning more. I think, Anne, hearing you talk about this, really, I think a lot of these issues seem to be really speaking to this broader sentiment that I've observed and heard within the ME community, that historically the community's concerns and needs and experiences have really just not been listened to, as you've mentioned, by health professionals, but I think even as by researchers and policymakers, and that often their experiences and voices do kind of go unheard or dismissed when it comes to talking about changes that need to happen. And I think that's particularly true when we start considering, as you touched on at the start of this episode, those who are more severely affected by ME, who might be really substantially limited in their ability to engage in advocacy and, to participate, and are often not seen. If they're not accessing healthcare, they may never actually be seen by clinicians. I guess I'm interested in, what do you feel would need to change to make sure that research and policy does meet community needs, but particularly still meets the needs not just of those who are on the milder end of the spectrum, but those who are the most severely affected, who might have the least capacity to sort of advocate for themselves as well?
It's a very difficult question because there's no easy answer. Bottom line is, when COVID came in and the federal government recognised that we needed to spend some money on it, they allocated $50 million to long COVID. And at the time, I remember speaking to several people in the bureaucracy, and I said, why have you put all of this money into long COVID and not ME/CFS? And the response was, well, we're actually hoping that by focusing on long COVID, we'll uncover something that'll help people with ME/CFS. When you look at the research spend on ME/CFS globally, and you look at what Australia has invested in ME/CFS research, it's embarrassing. So that's not to say that there is an unwillingness to listen to patients on behalf of government and do something about it. And of course, right now we're in this dreadful geopolitical situation globally where it is reasonable and it is understandable that governments are not necessarily focusing as much on some of the issues that we're putting forward because, there's sort of a couple of minor issues like the defence of our country and, tariffs and our relations with our neighbouring countries. So, there's kind of an understanding that, yeah, we get it. It's a really tight fiscal environment for government. And we've just seen that in our federal budget. For most of us in the sector, the federal budget brought very little joy. For those of us in the chronic and complex disease space, it brought no joy because there's no new money going into chronic conditions and the chronic conditions framework. The only money that's going in there is money that's been taken from organisations like Emerge Australia, where our funding ceases on the 30th of November, and put into a new pot that we now have to compete with and hopefully be successful. To get another tranche of funding. So there's wheels within wheels that are working. And we are certainly at Emerge Australia advocating very directly with those people in power, particularly those people in health, the minister, assistant minister, and advisors, to allocate a very large amount of money to MECFS research. But that can't happen overnight. We are hopeful of running a research priorities workshop in the first quarter of next year and develop a national MECFS research strategy that will be put to the MRFF for a very large allocation of research funding to bring Australia into line with, the funding that is being made available in other countries around the world, like Germany, for example. I mean, even the United States, in the state that they're in right now, there is more money being poured into MECFS research. The UK, the same. And then you've got Amsterdam, you've got the Netherlands, Canada, other parts of Europe. We pale into insignificance in Australia with any focus on MECFS research. And you can just imagine how those people who are really, really severely impacted by MECFS feel totally forgotten.
Absolutely. I think too also, because funding is such a huge part of it I'm a clinician researcher. And so getting to the almost tail end of PhD and looking at postdoc things, it becomes very apparent very quickly how much research is just contingent on funding. And that obviously makes things quite difficult in terms of supporting research moving forward. But I think the thing that I've observed as well is just the actual nature of research that gets done as well. And I think the thing that struck me from looking at most of the research we have is that there has been a real gap in research that meaningfully collaborates and consults and values lived experience, and is co-produced with the community, as opposed to simply, having someone who doesn't necessarily have or understand the condition particularly well doing research without any sort of input or consultation from the community to really understand those experiences. And I think, I would love to see that research funding, come up. I think there's such a need for it. But I think what I would be so excited to see within that is if we can start to see more research that really prioritizes that co-production and that sort of community engagement in research. It's something we undervalue and underutilize so much, in my opinion, from a health professional research perspective, but there's just so much power in it.
Yeah, and look, to their credit, our current government is hugely responsive to the voice of the patient. That has been, I think, in the last maybe 5 years, has been a significant shift in how government responds to organisations like ours. And we know that if we have issues that we need to discuss with the minister, they'll always be, we'll get a better reception if those issues are being led by people with lived experience. As far as research is concerned, and we're involved in a number of long COVID research projects, and that's only because of our registry and our access to patients. My view on how co-design is working is a little bit more cynical. I think that a lot of research, obviously research is a dog-eat-dog enterprise, medical research. It's all about survival of the researchers. We need to be very clear. Yes, their job is to uncover evidence, put up, hypotheses and a research program that will hopefully prove their hypothesis right or wrong, which is one model. That will hopefully then lead to something constructive for patients, whether it's in a treatment, whether it's, in medication or whatever. But a lot of research actually starts in the head of the researcher. And the inclusion of patients, whilst it's seen as necessary by the head researchers, is often confined to a consumer advisory group. And we only go to them for these things. But the rest of the work happens with the medical researchers because we're such important people. And so I'm a bit cynical, of course.
Yeah. Yeah. I think that's understandable. I think realistically, a lot of research that has sort of said or attempted to sort of involve people with lived experience, there has been a lot of research that has been quite tokenistic or quite controlled in terms of the degree of power that is actually given. And I think moving beyond those sort of arrangements into true co-production and co-design where you have that sort of engagement, with an organization like Emerge or with lived experience community, every step of that direction, from foundations to conceptualization of what the research is and how it's being conducted, and actually having people with lived experience as part of the authorship team and being involved in full capacity, I think is so important. And I agree. I think there's a risk that we sort of fall into this sort of tokenistic sort of involvement, but it does very much need to go beyond that. It's something that I think particularly within the ME community is going to be really important moving forward. So hopefully, maybe we see a more positive shift if we get this sort of increase in research funding, hopefully next year or the years coming.
Yeah, I mean, and there's some I don't want to put a sort of blanket thing over all research, but that's saying nothing for us without us. And starting before the beginning and ensuring that co-design actually is included in the thinking about the design of the project, rather than, well, we've designed this project, and in order for us to be able to get the funding, we really need a community advisory group. And so we'll put them together, and this is the little area we want you to be involved in. Because you don't have to be involved in all the others, because that's our area. And I might be being cynical, and there might be researchers, I don't think they'll listen to what I'm saying, but there might be researchers that listen to this and say, hang on a minute, you're being a bit harsh or whatever. And I apologize to those people. But that's the impression that I get. The reality is that given that we've been part at Emerge Australia of many long COVID research proposals, when we've sat up and said, but, what about MECFS? They say, well, we're not funded to do that. So it's very challenging sometimes. And look, medical research, make no mistake, dog eat dog environment, very political. No.
Absolutely. Absolutely. And I think hearing you speak about this, I think there's been a number of things that you've raised already that it isn't very much isn't just an individual clinician level that we need to be thinking. It's across systems. And you've mentioned a lot of things already in our episode so far, even things about Medicare funding and rebates available to support clinicians to deliver care, to research funding and how it's researched and what the research priorities are and what are the clinical guidelines and what sort of organizations and infrastructures are in place to help support clinician education. There's so many different layers. And I know, Emerge has been so involved in so much of this background work, and there is certainly no easy answer. But I think, to know that there's an organization like Emerge out there who's thinking and talking about these things and really trying to spur these conversations is at least a very positive step in the right direction, I think. So, thank you for the work that you're doing. I'm really conscious of time, and I feel like I could sit here forever and, ask you a million questions. But I guess to wrap up, knowing that we do have a mix of health professionals and patients who are listening to this podcast, I wonder, what would be your one key takeaway that people could walk away from this episode with? What's the most important thing?
People who have ME/CFS need to be seen and they need to be heard by their clinicians. And diagnosing early goes a long way to supporting patients and preventing them from falling into this really deep form of ME/CFS that leaves them severe and bedbound. It is all about ensuring that our clinicians and our patients have the time to truly listen to what's happening to the patient and then diagnose accordingly. I think it starts and ends for patients with diagnosis. If you're not diagnosed and you're sent home to rest or do graded exercise therapy or go and see a psychiatrist because it's all in your head, that just doesn't work. So believe your patients, clinicians, believe what they're telling you and use whatever training you've had and your knowledge of being able to reach out to others to be able to convey to your patients that you hear them and you see them and you're there for them. And if you need help, reach out. Organisations like Emerge Australia have got self-paced learning, clinical education. You can talk to members of our medical and scientific advisory committee. We've got lots of people who can support the clinician. And from a patient's perspective, I would say, if you're not getting what you need from your GP, go to someone else. I mean, Emerge Australia does have a GP aware directory on our website. Now, sometimes people move around and you can't find anyone close to you, but, avail yourself of the resources that are available. And you can always ring our helpline and talk to one of our nurses, but help is always available. And know to the patients listening to this that we at Emerge Australia, we are there solely for you. We see you, we hear you, and our work is designed to support you in whatever way you need. And we work within an imperfect system, and we are working to strengthen that system for the benefit of people with ME/CFS and other overlapping associated conditions.
Thank you so much, Anne. I know I'll definitely include the link to Emerge's website because I know that there's some really fantastic resources there that people listening might want to check out. So definitely, if anyone's listening and keen to look more, check out the show notes. There'll be links and things there. And I know that from a health professional perspective, there's also some upcoming webinars and things that might be of interest as well. I'm actually excited. I'll be contributing to one in July around pain and allostatic load, but I know there's a lot of different sort of ones and that will come up. So definitely, if you're a health professional and looking to sort of upskill, I would definitely recommend checking those out. It's just been so lovely to be able to chat with you, Anne. And I think to hear your passion and advocacy come through so strongly in an area that it can so often feel like we're just pushing things uphill. Thank you for your tireless efforts and passion, and to the whole team at Emerge as well, because I know there's some really important work happening. And I know from speaking and working with patients, I know there are a lot of people out there in the community who really appreciate the work that you are doing. So thank you so much. I just want to say a really massive thank you to you, Anne. I know that you are incredibly busy, and so I really appreciate you taking the time to come on the podcast and to share a bit more about the work that you and Emerge are doing. So thank you so much for taking the time, and it's been really lovely to chat to you today.
So much for having me, and it's really been a pleasure. And yeah, it's been a wonderful experience. So thank you for having me.
Thanks everyone for tuning in, and hopefully see you all next time. If you enjoyed this episode, we'd love for you to share it with a friend or a colleague, or maybe even leave us a quick review. Don't forget to subscribe so you don't miss any future episodes. If you've got an idea for a topic or a guest that you'd love to hear, definitely send us an email at podcast@vivepainfatigue.com.au. If you're interested in more resources or information, head to our website where you can find out more about our clinical services and our professional education. Until next time, take care.